Hey everybody, welcome to CARDIOcast at the Pre-Hospital Paradigm Podcast. It's our special extra episode for all 2025 on the 5th Monday, so I hope you enjoy. Guys, let's hop right into this discussion, and we'll start off this first episode talking about kind of cardiology and cardiology interventions for the BLS provider, right? And then in subsequent episodes, we'll talk about some ALS interventions, and we'll get more into pharmacology and electrophysiology. But let's talk about what can be done in the BLS space for our BLS providers. And I guess we have to kind of preface this a little bit with, we're attacking this from the Ohio scope of practice mindset. And for our out-of-country and our out-of-state viewership, things can vary, right? So I don't exactly know how every state lines up, but
I think it'd be cool, though, to see also if the viewers are from those areas. Post what the differences are. I'd like to see that.
We'd like to see. We'd absolutely like to see what some of those variances are.
I see you guys are giving, aspirin. We don't do that. We use this. I think that would be cool.
Yeah, no, absolutely. But let's start with the stuff for the BLS provider. So, of course, in Ohio, an EMT can use an AED, and that's not news, right? Lay public, of course, can use an AED. But then we get into some kind of clever trick wording with our scope of practice when it comes to some medications, and then we have some allowances for newer technology to be utilized. Relatively new, I should say. Certainly stuff that's evolved in my career. I guess let me say it that way, with 12 lead EKGs and whatnot, utilizing that in the BLS space. So that, I think, certainly in chart review and things that I come across, and John, I'd like to hear your thoughts on this, but I think it's often underutilized by the BLS provider, specifically the pieces where in Ohio they're allowed to obtain a 12 lead EKG. So we have this kind of have this bipolar messaging to them, which is, You can't on your own put a 4-lead on and watch rate and rhythm. You can't on your own put a 12-lead on and interpret it, but you can place that EKG
and transmit it. And
use, again, I guess more relatively recent, last 10 years technology, and transmit that for interpretation by whomever. Yeah. We were kind of talking offline here, where most of that's
typically
to the physician, yeah. Right? But we were working through, even in our own system, where there's some variability where people are having paramedics interpret, and whether that should become the norm, or whether it whether we can be a bridge, because we have a model here in our system, in the UH system, where there's a quarterback that handles all incoming EMS traffic at the hospitals. So that might not be a model that's necessarily, that might be kind of unique to us.
And it's not in every one of our systems either.
In all of our hospitals, certainly in all of our larger hospitals, absolutely. Yeah. Anyway, your thoughts on that 12 lead transmission and acquisition of the EMT. Are you seeing any, because
I have a lot of
EMTs under your umbrella, and I know you see your paramedics do it.
Yep.
Because you would be scolding us and them if
I do,
and you often do have to, right? But
I think it's super important, right? It's just one more piece, and what's nice about EKGs and really any other of that, it's not subjective information, it's objective, right? Yeah. So I'm not relying on any one EMT paramedic in the field trying to tell me this is what I see. No, I can look at the data itself and then interpret that data individually for myself. So I think it's hugely valuable, especially if you guys, if the basic in the field is obtaining that EKG, transmitting it to us, they don't understand what the squiggly lines are. That's all right. Not all doctors do either. But we can act on that information as we get it, even before I get a phone call from you in the field. So getting that initial EKG in the field for all patients that's appropriate to, which honestly, most patients it's appropriate to get a 12 lead on. Any arrhythmia, and that means bradycardia, and it means tachycardia. If their heart rate's 101, you should be getting a 12 lead on them.
Right.
Just so we can see what that dysrhythmia is. Or it could be we throw it on and they are having a heart attack.
Yeah.
Now, mind you, if it's an 8-year-old that rolled their ankle, they don't need a 12 lead done, right? Mm-hmm. But most patients, it's appropriate to put on the monitor, to put on SpO2. If they're short of breath or it's a breathing concern, end-tidal CO2 is paramount, and goes hand in hand with cardio.
Yeah.
Absolutely.
And
with
even
circulation.
on a basic level, if they're seeing squiggly lines, basically they know that they are at least perfusing in some way, if it maybe not mechanically, but at least electrically. And I think that goes hand in hand with capnography, that it's instantaneous. We're not waiting on something to happen like pulse oximetry.
Correct.
So you can see instantaneous changes. Even if you don't recognize the rhythm, you know it's changed.
Yep. And your devices that are monitoring the patient, if you have that 12 lead on, it's going to automatically fire if it sees a rhythm change. Absolutely. And it's going to capture that, right?
That's true.
It's going to alert you that it's that extra. Right now in 2025, we're on the precipice, and we're integrating AI into the care of medicine. It's happening in our system, and we're kind of involved in some of that too. But I mean, we don't have AI devices in the field yet. We do have pretty intelligent devices to recognize rhythm changes and key off, like, hey, like you've said before, the best tool a paramedic can have is a great basic by their side to say, hey, the monitor changed. Hey, your patient's condition changed. It's just a little bit dumber than a basic paramedic saying, hey, so I noticed a change. You should investigate what's going on.
Yeah, and we know that all of our good assessments start with good basic skills, and we were harping about this earlier today.
We were just talking about this today.
Without
Absolutely.
a hands-on and visual and good primary assessment, which is well within the basics protocol, you shouldn't even be worried about the next step yet. So
correct.
Any good basic should pull a medic back, pull a doc back.
Well, we do the same thing too in the hospital, right? You bring the patient in, you offload them, we get them hooked up to our monitor, we triage them, and then all of us leave the room if they're stable and or somewhat stable, right? That monitor's on them for a reason, to alarm, to say, hey, patient's not breathing. Hey, the patient's tachycardic. Hey, the patient's bradycardic. Hey, they're hypoxic. Hey, CO2s or end-tidal CO2 is out of range.
Yeah.
Like, we have those ranges on there for a reason, so that way we have a piece of equipment monitoring the patient when we're not physically in the room to have eyeballs on them.
I think one step back to think about also is, I love Emergency, the old series, Los Angeles County Emergency.
Yep. Mm-hmm.
In that series, I mean, that aired how many years ago, and they were sending single lead transmissions even then to the ED doctor to interpret.
Yeah.
And this isn't new by any means, and they were paramedics, but not to the standard we are today. So they were giving good care based on transmission of EKG single lead. And I mean, that's
at that time,
cool
right?
to me. So it's not new.
But that single lead could say, oh, that's a narrow complex, that's a wide complex tachycardia.
Yeah, exactly.
I can eyeball that and say, ooh, that's a pretty long QTC.
Sure.
I can get more information even off of single lead. Maybe
see
not high fidelity, but
irregularities, you'll see widenings, narrowing, and you also see any type of maybe heart block.
Correct.
So, I mean, it is valuable, one even lead information.
It's better than zero.
Agreed. And I guess that's kind of the thing we need to channel back into here is, for the EMT provider, we know those things intuitively. Is this wide? Is this narrow? What's the QTC? All the things that we, I actually find it hard sometimes to teach cardiology, because at this point in our career, what do? You hand it to you and you do the rule. You do the rules instinctively, right? Uh-huh. You read it as you've trained yourself to read it, or you've been trained to read. You do it to slow down and then break
access.
Right.
Is there all that stuff happens? EMT is not taught that, nor at this juncture do they necessarily need to know that. Now, we're going to talk a little bit about. You're allowed to know what those things are. You're allowed to know what those wavy lines are. Our prohibition in the state is acting upon that. Acting upon that information. Yeah, right. That is reserved for the advanced provider, for in some cases the advanced EMT, but certainly for the paramedic. And you talked about a BLS assessment, right? That the rate, rhythm, the quality, actually touching your patient and getting a radial pulse versus a carotid pulse, just the vast amount of information that you get from that, right? So when you talk about cardiology, we kind of jump to all wavy lines and transmission and electricity, but it really starts with that. You're 100% on with that, and John, your point about the objectivity of that, but I want to go back to kind of a underpinning of this entire series is the story tells all, right? So it's
before we had all these
a combination of these three things.
Yeah, before we had all this fancy machinery, and before we had LifePak 15s on all the ambulances, and before we get ultrasound or AI or whatever, the story still tells all of it. Like,
sure,
that's what we had up until very recent times, and what I would consider more modern medicine, the last, we'll say 20 years or so. Before that, it was all history and physical.
It was all stick and rudder. Yeah.
The testing platform we use for the paramedic program, I can't give away the identity of that if I give you the next part of this question, but one of the questions literally is that the correct answer is 85% of the diagnosis a physician will give to a patient is based on medical history, not test.
Yeah.
And so, that alone should tell you.
We're doing tests to confirm what we think the diagnosis is.
Yeah. Yeah.
And then especially when you come to the emergency department, we're going to shotgun a few things. It's all shotgun, right? We don't asterisk there. In a normal patient, I will go see them first and put in orders. That's not always possible if I'm trying to be time efficient. If my nurse has seen them and I've got a brief history of what they're in, I will sometimes put in orders in just to help
expedite the process,
right?
Absolutely.
And nursing's been trained to put NIP orders in, so nurse-initiated protocols.
Yeah.
So they're allowed to do that. But it's me going in and having a conversation with them, and there's often times where we'll put in an order, or someone else will put in an order, and I will go talk to the patient. I'll be like,
we need to add some stuff or change something.
We should. That's an appropriate order to order that because I got more information from the history that test isn't going to be appropriate in this situation. And in emergency medicine, at least, we're there to diagnose, and we're there to make sure there's no life threats. That is our underlying concern. We want to make sure that you live to see another day. Yeah. We're not necessarily there to diagnose. We often get the diagnosis, but there's sometimes I go into a patient's room. I go, I don't know what's going on with you. I don't know what's causing your abdominal pain, but I know that it's not these three things that are going to kill you.
It's not these lethal things, right?
I do think if I might, just as an instructor side, I'm sure you'll all agree, that it's easier to teach somebody who hasn't already learned bad traits EKG reading. So I love cardiology. I love teaching cardiology, and usually within a half hour of my lecture, I have students interpreting EKGs. It's not hard. What is hard is you get somebody who has read a couple books or taken a couple YouTube classes, and now they're reading EKGs. That's hard to beat out of somebody when you start not looking at the rules of reading. So I do caution viewers who are basics on that, but just seeing something for what it is doesn't hurt either.
You practice like you're taught. That kind of underpins what I said a few minutes ago. Is I instinctively start looking. I pick it up and I'm reading it the way I was.
You have a system.
Functionally,
you have a system approach.
The way I was taught.
Does every QRS have a P wave? You determine all those things. And I think too, to tie into what John said is, and you all are saying it. A lot of it is impression, right? Not just with your vital signs, but what do they look like? How do they appear to you, right? So if it's 98 degrees outside and the patient's like, I'm having crushing chest pain, they're sweating, they're pale, they're sitting in the front lawn, I was mowing the lawn, my chest is killing me, and they look terrible, right? A lot of it is primary impression, the whole like sick, not sick thing. We talk about that a lot. So how do they appear, right? We can all walk in and be like, damn, they're sick. We've all walked into that room or that patient's house.
Gotta go.
Or you've heard it and you're like, yep, we gotta go. Like, they're sick. So I think that's
a point. Yeah, we walk into a scene and you say 90% sure he's having a STEMI, and then when you hook him up on the monitor, be surprised that he's not.
Correct.
So it's like, I get what you're saying.
And where I was starting to go with that is those three pieces, right? A good assessment, a good BLS assessment, a good story, and then the objective data. Even if the objective data shows a perfectly clean EKG, but I say,
story doesn't match.
John, we got all, let's use this. Use the story you just gave, right?
Yep.
Crushing chest pain, but the EKG is clean. You're probably still going to have that EMT act like that patient is having a myocardial infarction, having a heart attack, right?
We'll get that 12 lead, and in the case, like if the scenario presented, if they say this feels like my last heart attack, I'm still activating a STEMI even though the EKG is clean. Why? I would rather overactivate and over-treat that
100%.
and over-triage that
Yeah.
to get cardiology at bedside when you roll in. He goes, yeah, but it feels like the exact same time.
Exact same, right.
Well,
That's-
and then also, how many times has you maybe had somebody that came in not for a STEMI, but you've ran lab work and maybe a troponins come back where
Yeah,
it's
it's
like,
an
oh, let me
in-STEMI.
look at
Yeah.
this.
Yeah.
It's an in-STEMI. And then there's where your gastrointestinal pain's coming from. It's like,
Well, I think maybe the other question too would be is like, say, let's use medical command kind of to piggyback off what you said as well. Let's use medical command. Hey, I send you my 12 lead. I call into you and say, I transmitted you my 12 lead. Dr. Hill, what do you think about it? I give you the story, and then, maybe your question to that provider, if you don't get a good picture, might be is how do they appear to you? Right? Do you find yourself ever saying that? Like, how do they present to you? Like, well, they look really sick. They're pale. They're flushed, they're sweating. Like, do you ever want more of that maybe from possibly the EMT sending that 12 lead in? Like,
I do, because my first thing I say is like, what's going on? Like, why did you send me this 12 lead? I want to hear the story as to why, because it'll give me a better, I want to
Context
to interpret the information I'm looking at. Because, they're having mild chest pain, and I got it because I need chest pain, and I need to decide whether I need to go to a cardiac center, a STEMI center, or can I just take them to a regular emergency department? Okay, that's normal sinus rhythm. I don't see any signs of ischemia. You can take them to a regular emergency department.
This patient passed out, or this. What
triggered
you to do
pain
this?
between his chest ribs. Like, well, that's probably not cardiac. So pump the brakes.
I think appearance is a lot of that, though.
But
like, I think that's a huge.
Because they'll lead off with like, they're pale, they're diaphoretic.
Yeah,
they're having shortness of breath. It's worse on exertion.
Yeah, those are key things to relay, I think, to the EMT provider that's transmitting that 12 lead, right? I'm just staring at the 12 lead, but I don't have a story yet. The phone hasn't rang, so I'm just staring at that 12 lead, interpreting it, and then you get the phone call. I think we want to encourage those EMTs to not only just fully describe your primary impression, your primary assessment, what they were doing, tell the story, but they look bad, right? They look flushed, they look pale, they look... they look sick. I think that's a big thing to relay.
And we've talked about this in, I think, one of our communication, probably in multiple episodes, but, lead with the hook, right?
Yeah.
I'm bringing you I'm bagging an unconscious, unresponsive, 56-year-old
Start with the
male,
worst thing first.
and they're like, but same thing. Hey, I'm bringing you a, pale, cool, clammy, diaphoretic, altered mental status, and you're painting the picture, right?
Mm-hmm. No radial pulse, systolic blood pressure is 60.
Right? Yeah. I mean, those quick hits that
big.
really just grab you and be like, yeah, okay, this is legit, right? If you have that super sick case, right? Kind of bundle those things right off, and you're like, oh, okay, now you want that context, and then you're looking at this and be like, oh, okay, then
Well, to that point, if I'm asking for context, it's probably a normal EKG or normal-ish looking EKG, as opposed to you send me a clear STEMI. You're calling, it's a STEMI. Catheters on their way in. How far out are you?
Yeah.
What have you given? Yeah. That's what I need to know.
Sure.
It's a STEMI. It says it's a STEMI.
Yeah.
Well, it doesn't say. The computer might interpret it as a STEMI. I, as a physician, are reading that and agree with that interpretation that it is a STEMI. Or you guys could send an AFib with RVR. Yeah, I already know it's AFib with RVR. You can tell me a story, but I know what's going on here.
Yeah.
Well, and I think the huge thing is, too, and we had a great success story out of Portage, where we actually did a run review with Dr. Gupta. 2 EMTs went on a call. It was for chest pain. It was Newton Falls Joint Fire District. Walked in. We had just taught CE there that month. Walk in. The patient presents they look terrible, so they put on a 12 lead, they transmit it, they call, the doctor's like, yeah, it's a STEMI. They're like, okay, we're just going to put him in the ambulance and drive. So I think, too, the other point we're trying to make is there's not always going to be a paramedic provider there.
Correct.
So they recognized, my patient presents sick.
This is bad.
Terrible.
Right?
This is bad. Did a quick EKG, transmitted it, confirmed, it's a STEMI. Where are you coming? We're going to come to you. We're going to put him in the ambulance. We're going to start driving.
Yep.
And they did, and they had a great. I think their on-scene time was less than 10 minutes.
That's awesome.
They drove on the red to UH Portage. They picked up a paramedic in, I think, Ravenna Township, Ravenna City, to try to get a couple things done. But didn't delay that transport. They literally pulled over, got in, shut the door, continued to drive, brought the patient to the emergency room. So I think there's a lot to be said for a lot of our EMT departments, especially in the rural areas. So what you do matters, how you control, and I'm sure we'll get more into time with these cardiac issues, what you're going to do and the decisions you make and how you can compress time or control it in that environment is paramount. That is a huge deal, right? And instead of, I'm going to camp here for the next 30 minutes and wait for a paramedic.
No, that's
No,
the
like
absolute
we
worst thing.
But let's-
encourage, and when something we do in our systems is we encourage if they look sick, do the 12 lead, talk to you. They did everything right.
Awesome.
And we had a door to balloon time of like less than 15 minutes.
Well, let's say that
I mean,
is
it was
a
and it was
double medic
mainly
squad.
all EMT care given.
All EMT, yeah.
You know, that's
Let's
huge.
say it's a double medic squad that showed up to the same run. What in the world difference are they going to make when what does the patient really need at that point? They need a cath lab.
Right.
Yeah.
So whether it be a basic or a medic squad, they did exactly what they needed to do. They got the information, they transmitted it, and they took off.
Well, the best thing you can give the patient anyways is the
Aspirin. Let's
Yeah.
say
Yeah.
we need to talk about we need to kind of work that into the discussion about what's important here. Right?
Well, if we're talking about outcomes for
Yep.
these patients, right? STEMIs, it's not
Nitro-
the heparin, it's not the Burlington, it's not the
not the
heparin.
it's not the
It's
nitroglycerin.
aspirin.
It's
Aspirin's
aspirin.
the only
Absolutely.
thing
and
that
in
we
not
have.
so distant protocols, we're not even allowed to give some of those medications as paramedic providers. So, I mean, that should just go to show you that it's not high up on the importance list. It's important, but not.
Yeah.
It's not like the basics can't do the aspirin, heparin. They can't do heparin, but aspirin and nitro, they can do it. So, just recognizing.
This is one of those cases where, as a paramedic provider, I have some value added, but I don't necessarily.
I think I'll be honest, the only value a paramedic provider adds to the STEMI patient is the ability to start an IV
Yep.
and ability to provide fluids if you're giving nitro to control blood pressure.
Yeah.
Fair, and
You can give heparin and Brilinta. That's going to help in preparation for the cath.
I think it's some of the longer transports, to your point. Yeah, I think, to Caleb's point, I think the aspirin is key. Compressing scene time is key, going to the right center. But I do think in some of the longer transporting agencies that we have, not to go deep into the paramedic realm,
Yeah.
but the heparin and Brilinta, we have seen EKG changes
Yeah.
for that 45-minute,
correct.
that
Absolutely.
45-minute transport where you are getting some point of, I don't want to say reperfusion.
Could
that
be
coroner.
helpful, right?
Yeah, it could be helpful
Could
over
be
that
helpful.
long distance transport time.
but the
key is still aspirin.
The key
Oh,
is still
I
aspirin.
don't disagree.
It's a BLS.
Sure.
Yeah, it's a BLS intervention, right? My
100%.
value adds over there, and I would argue even analgesia for the patient's sake. We know that doesn't change outcomes.
I'm talking straight
Yep.
outcomes.
Yep.
Data.
Disposition, it's going to
Yep.
be aspirin.
30, 90 day. Yeah, more time.
And
Yep.
I see it quite often that if you get those medications on board all at the same time, by the time you get to the ER, STEMI is already activated, cath lab's either ready or getting ready. We get a repeat EKG, and it's normal. It's resolving.
Resolving, yeah.
But we're still taking them to the cath lab because they
100%.
still had their event.
Absolutely.
We still need to figure out what's going on.
So a rhetorical question to you as a med director.
Then no.
Can a basic EMT place a 4-lead and then a 12-lead EKG and transmit it to you?
Yes.
So,
There is.
can
now,
they
I will-
read the EKG?
No. They can. I would encourage them to read the computer interpretation of what it says because it's going to guide you in some directions, right? You can report that. That's not the basic provider interpreting it. It's them just reading what the computer says it's going on.
Yeah, you're still relying on the physician that you're
Yep.
talking to interpret the 12 lead for
Or
you
whomever's
per the scope of
interpreting it.
practice. Yeah, or
But if it
whoever's
prints out
interpreting.
and it says acute MI,
Then you need to
Sure.
make a phone call.
yeah, and then maybe that would give you a clue to start packaging up early and get it
Yeah.
going on the road and heading towards your STEMI center. Still give me a call. I should already have that and say, yeah, that's a STEMI. We're already getting ready for you.
Yeah.
Or no, it over triaged.
Yep.
Yeah, your machine over triaged.
No, this is
It sees this old stuff here. This is
Yep.
all old. No, I'm not necessarily as worried about it. Your story doesn't
Yeah.
match.
Yeah.
Yeah, absolutely.
This looks like a left bundle branch block.
Yep.
Yeah.
Now that's a little bit different where we as paramedics are cautioned. There's a white paper out in the state of Ohio that cautions us from it. Leaning on that interpretation too much. But
I would say don't even look. I mean, how many times, and you guys have either seen us do this or same way, I get a 12 lead, fold it over.
We all fold it over.
I just ignore it,
Right.
and I hand it to whoever my student is. I say, interpret this. What do you see?
Exactly.
The only thing that I rely on the top of that for is timing measurements.
Correct.
Yes.
It's probably not the best. Anyways, I'm going to verify them by looking at what the measurements are, but I'm going to count on the computer to be like, yeah, their QRS is 96 or their PR interval
Their
is.
QTC
Those are
is
pretty
100.
they're spot on because any of us that have taken like a Tim Phelan 12 lead class, that's one of his big things he'll push is like the one thing that specifically the LifePack 12 or the LifePack 15 does is it registers time extremely well.
Yeah.
Yes.
So yeah, I'll usually not pay attention to the interpretation, but like I will guaranteed look at the width of the QRS, see what it's because it measures it measures time
pretty
extremely
well.
well
But
to the point like you don't have to double check it all the time.
Yeah, but
You just don't want the preconceived notion of STEMI up top or left bundle. I will look, and then I look up to see, okay, my QRS width is this, stuff like that.
If we want to get really nerdy about it, it says acute MI and my QRS is 125. I need to
I'd probably have a bundle.
I've got
Yeah.
You're doing the eyeball test on
all the measurements.
on all the measurements, right?
And if the measurements line up, like, yes, I'll accept that as fact.
Right.
But there's also times, especially when it comes to like QT and QTC, that I don't necessarily always agree with it. And I spend a lot more time questioning those measurements because if anything's going to be off, it's going to be like, I feel like the QT is the most off. Obviously, QTC is a calculation based on. I do not do the QTC calculation.
Just straight QT. Yeah.
I always find my eyes go right to the bottom right corner, and I read those first. Can't help it, but that's not for today.
Nope, that's for one of the other episodes. So, in that placement of that 12 lead EKG, you kind of led in with, can they put a 4 lead, can they put a 12 lead on? Yes, they can put it. They can certainly assist another advanced provider with doing it, but I think we need to then talk about making sure our landmarks are appropriate and then proper skin prep. Yeah,
skin prep is huge. EKG electrodes, how are you storing them?
Yeah.
Right. So like
And
a lot of us
not
buy.
busy, make sure they don't dry out.
Yeah, a lot of people buy. So let's start with the
We'll
electrodes.
start with
and
the
then we'll move.
electrodes. That's fine. Yeah.
So electrodes, not all electrodes are created equal, right?
Oh.
I mean, that's just be completely
Right.
honest. We buy, I don't want to say the name brand, but we buy a more expensive electrode in our place
Palmodine
with a lot more.
electrodes.
Oh, God. We buy a lot more expensive electrode that's larger, a lot more gel area. They're extremely sticky versus, if they're the cheapest ones on sale, they're probably not going to give you the best picture.
Absolutely.
So I think that's one of the biggest things. But we also buy them in 30 packs. So as soon as you open that, even though they all have their own plastic backing,
Timer starts.
You need to store them in some sort of a bag because air is going to kill the actual gel, which is going to give you good conductivity to the skin. So that's something you need to be cognizant of. Or if you run a lot of volume, we run a lot of volume. So our packs usually get opened, like resealed in theory, and then put back in a Ziploc bag.
That's a day or two's worth of
That's
electrodes.
usually, we're usually going to blow through a pack or two a day. So we're going to burn through them. They're not going to dry out. If you're a little bit slower, then maybe you should flip and buy electrodes in the 4 or 5 packs. Four or five packs to avoid that. But a lot of people overlook that initially and think, all electrodes are created equal. I could just buy these. These were cheap. They were on sale.
This is what I get from the hospital?
Not true. No. And what you're getting from the hospital might not be the best. We use 100%. One that comes in a gold pack that's a little bit more pricey, but we get a lot better picture. Yeah. So it starts with the correct electrode, not allowing them to dry out, and then you move into skin prep, right? So not to piggyback to Tim Phelan, but he preaches this in any of his classes, and we've all sat in them, and he's a very intelligent person. First I need to wipe the skin actually with a towel to remove the oil from the skin. Then I need to, if you flip that electrode over, there's these little perforations on it. And everybody's like,
what's that for?
What's that for? Do we need to use that? Yes, you do, actually.
There is a purpose.
If you've ever went for any type of a stress test, that is probably the best example of how a 12 lead needs to happen, would be my example to the audience. So if you've ever had a stress test or watched somebody, they wipe the skin, they want to try to remove the oils, they flip it over, and where it's perforated, they are going to scratch your skin, try to remove any dead skin cells, epithelia cells, and then they're going to place that electrode on your skin. So it's like we're doing all those steps, and everybody's like, nah, it's fine. Stick. Lift up your shirt, you're sweaty.
To your point, if you've had a stress echo, how clean is that EKG as you're running? It's clean.
Even while you're running.
Yeah, even while you're running.
Mint.
Everybody that tells you that, you had a rash of like 360 cycle interference strips sent to the ED in 1 month. That's skin prep. It's clean. Stress, like to your
stress,
point.
That's like my best example of when people, or maybe like the EMT provider that's watching this, thinking how important this is.
It's important.
If you've ever had a stress test, that's probably the primary importance, and gives a good example of you have to have quality electrodes. They cannot be dried out. You have to have good skin prep. You need to remove the oils. You need to remove the epithelia cells. You need good content. And then the other thing would be is you need to try to eliminate other outside noises, right? So LED lights are really cool. And there's other devices that will actually affect monitored equipment, right? I mean, we're going to get new LED lights in our fire station installed, right? one of the biggest interferences that they have to send an electrician out to check is, will it mess with our frequency of our garage door openers, right? Who would have thought that? It's just like, well, we're just going to get LED lights. It's fine. And he's like, well, we're going to send an electrician out. No different than your monitor, right? So that's why we preach in our system, we're so big, take the monitor into the house.
Yeah.
You know, if the TV's
everyone
on,
should be doing that.
If the TV's
if
on
it's in
60,
your protocol or not,
you should. You need to bring the monitor to the patient because that person that says, I have chest pain, I'm short of breath.
You make them walk.
I have pain on inspiration. I have abdominal pain. Typically, the first thing we're going to do on our assessments, get the story and do the 12 lead, right? And that's a great EMT skill. But take it into the environment. Usually the TV's on 100, so turn the TV off, right? But then you eliminate some of those other items because as soon as you get in the truck, we have an inverter, we have LED lights, we have all these other outside factors that could affect the quality of your EKG. Because, I mean, it's terrible when we send this EKG that looks like I've shaken the cords the entire time. It looks like VFib. I send it to you and be like, hey, doc, is this systemic? And
I can't tell.
You know what I mean?
This is garbage, right?
Yeah, it's a garbage quality EKG.
Absolutely.
So I think that's another factor for our EMT providers and paramedic providers to think is what type of outside noise or other frequencies could be affecting your quality of your EKG.
Yeah, I want to kind of...
Sorry, I kind of went full tilt.
No, that's fine. I wanted to kind of build off what you just said about that. You know, first about taking the monitor in, and then about some other healthcare facilities and taking the monitor in, and then interference. But you know, the taking the monitor piece in. How often is your dispatch information correct? It's laughable. It's not even a question to be asked, right? So you're like, we got
they're a seizure call, and 5 minutes later, they're not breathing.
Yeah. Well, there's a reason for that,
seizure,
right?
But yeah.
But just take it. Just drag it with you. Just take it in with you. You don't have to put it on if there's no indication. But how often do we get some bogus dispatch and we show up and it's like, I was not expecting that, right? Not only do you look like a complete tool when you're, running back out to your ship to get your
especially
when
it's a long travel, like a healthcare, like you said, you're going up to a third floor or something. You take it with you.
Yeah, and then the other point I wanted to make specifically with the 60 cycle interference is if you go to healthcare facilities, go to nursing homes because they're abundant. Everybody, a lot of people have them, or you go into a dialysis center or something like that. I've had numerous times, like you put the monitor in between their legs on the bed or something as you're working on the patient or whatnot. There might be a pump on the end for the air mattress or the sand bed or the DVT prophylaxis or whatever. There's electrical things that will interfere, or that wound vacs or whatever we're talking about, IV pumps, right? So. Again, if you're getting that garbage tracing, right, it might be just as simple as like, well, let's put it over here on the floor and look at it again, or let's put it over here on the nightstand, or
it's like walking around with a radio.
Here,
you can find a better signel.
In some regards, yes, but we often say we plop it there because it was convenient. But what we don't think about is what's saturating that is messing up that oscilloscope. It's doing its job exactly how it was intended.
And to your point, not only the outside noise with that, and you're looking at the picture, what about the leads, right? We've all seen the patient where they are like taut.
Yeah.
And they're like, I'm not getting a good picture on my 12 lead. And it's
kidding.
like, because you're literally trying to pull them off of the cot with your 12 lead EKG cable, so you're not getting a good picture.
And you got to be careful how you store that stuff too. If you're wrapping it super tight in circles and shoving it in there, that's not good on the cables, and they will wear out eventually, and you'll start getting false readings.
And they'll break internally.
Yeah,
and those.
That's true.
I mean, I think we've all had to deal with that at some point, where you'll have a cable and you'll bend it this way, and it'll be it'll be a nice tracing, and then you let go, and it'll be like you drop a lead, But
so okay, if I'm a basic provider and I've had somebody who was in cardiac arrest and I've shocked them and I've got the fast patches on, is it important to you then that I would maybe go back and do a 4-lead over top of that, or even maybe a 12-lead under it?
After ROSC, yes, but during cardiac arrest, no.
Because it's showing me squiggly lines.
Well, you're basic. You can't interpret that.
But it's showing me something, and I know that I just heard on here that I should probably send you a picture if I could. So if they're alive again, I've gotten ROSC.
If they're alive again, yes, you should absolutely transmit a 12-lead.
I think
With the LifePak 15s, you can only transmit a 12-lead.
Correct.
the 35s, I think, or maybe with the new Stryker software. I'm not sure which.
You can get a 15 that'll stream that.
Yeah.
And then, of course, the 35 will as well.
You can transmit the 3 or 4 lead, but not most places can't. Like even my shop right now, I cannot. They'll try to send me a 4 lead, but all I get is vital signs. I don't actually get any tracings.
Yeah, that snapshot,
gotcha.
snapshot option
Yeah.
when you're trying to transmit. Yeah.
So I don't get lead looks.
Okay. Yeah, no, that makes sense. And I think it's important, especially on maybe the 15s.
If you put the 4 lead on, just
the 12.
round it out. Just
Yeah,
go ahead
just
and put the other
some more stickers.
put the other
I-
6 leads in.
That was where I was going to start with this, but then also that you're still going to be on paddles. You're probably not going to see those, but if you acquire it, it'll still pick it up. So you may not see the leads, but it'll acquire it
Correct. Yeah,
because you're still going to be on paddles, and you're still going to see hopefully squiggly still.
And if you're, I think the 35 will show you all 12 leads.
It
Is that
does,
correct?
it does,
yeah.
And then the 15s, you do not. You'll just see whatever
It'll print.
leads you've had, and it will print
Yeah.
Up
the
to
12
3,
lead
yeah.
days.
You get 3 banks or 3, I think.
You get-
And as
usually you get 3 leads, and then you'll typically get like you'll get like SBO2 or end title if you want to see the other one. But you'll get 3 leads on a 15, and then typically on the new 35, you'll be able to see all 12
It's
or
amazing.
all 12 essentially going across the screen. Whereas more so like with the 15, it's more print driven. You're going to see that way.
I guess as a basic interpreter, not interpreting EKGs, but a patient interpreter, somebody who you might have revived is probably suffering from some sort of a STEMI event, and it would be good
there
to
was
get
a reason.
something.
It happened for a reason.
For a reason.
Yeah,
So it'd be
yeah,
good to
and
get
we're
that
looking for causation.
post-arrest
Yeah.
and then letting you see that and passing that on to the cardiologist. So I think it is a good reason to get one.
And a couple other things with transmitting 12 leads I just thought of too that we try to preach is if you're using a LifePak 15 specifically, you can click options and put in like a first name, a last name of the patient. You can also put in their date of birth. So the nice part too is if you transmit that to the ER, maybe you can give me some feedback is if I have my patient, I don't care if you're an EMT or you're a paramedic, I've done this 12 lead EKG, I'm sending it to you. Now you have the first name and the last name of the patient and the date of birth. So if they do have an abnormal EKG, or I could say, hey, this person was just seen at your facility in the past month and they had a STEMI, that could allow you to access their medical record to pull up a previous EKG.
It would be, and oftentimes cardiology will ask us for those prior EKGs, but I will just have. I don't have a name. I don't know who this is. I just know it's coming from this city,
fire,
and I know the patient's age. But if you do put that information in, I can absolutely pull up their medical record based upon that information gets transmitted.
And the 35s make it so nice. It's all touchscreen. You just
it's
the
easy.
name and you're done.
Yeah, throw a name and a date of birth in there when you're transmitting it. And I mean, let's face it, it doesn't matter if you're the EMT that's going to be writing this chart, you're going to be importing this into your EPCR anyways.
Yeah.
So why not take the extra 5 seconds and take the next step to do it?
Well, oddly enough, we were talking about right-sided and posterior EKGs earlier today.
Yep.
Yeah.
And on the 15, to the best of our knowledge here, and the Google, you cannot
What the Googler says.
you cannot document that as a right-sided or posterior EKG inside the LifePak. However, if you put a little note on it like
Right
John
side.
Hill right, John here POST,
Yep.
we're going to be able to figure out what type of EKG
Which
that
to
is.
me, after that conversation, really seems like an oversight.
Completely
Like
agree.
if you're listening out there, LifePak, make that an option that you could select it and it would be bold for you to see that this is a right-sided EKG. I know the 35s, they're just sending it all now. So, I mean, they'll get it. You'll get it. But it would be nice.
All right, so we went through the patches, we went through
Yeah,
interference, we're going to the leads now.
Yeah,
the
I
placement.
wanted to talk a little bit about, you guys were talking about getting a good tracing, and specifically at my old shop with my EMTs that were generally pretty good about getting 12 leads on patients if they were a double EMT ship. But I can't tell you how many just had the limb leads and then had dotted lines in V1, V2, V3, V4, V5, and V6. And the reason for that is quite simply either, they forgot to attach the precordial leads, or they didn't have it seated all the way, right? So if you're not, when you, as an EMT or any provider, right, if you don't have all of your EKG data populating all of the screen.
Something's
wrong, right?
I will tell you that, to your point, you can force an inferior side EKG look with just these leads on. Because if I know it's triangle and the way that works, I can get a quick inferior look, but it's not really good. But you need the rest of the leads.
Yeah, well, yeah,
But that's what's happening.
always should be. You should be always be doing the diagnostic piece with the full.
With the 15 though,
12.
if I put on just these cables and hit 12 lead, it's going to tell me to attach the cables. If I hit it again, I can override it and get one to work, and that's sometimes what's happening too.
Yeah, but you know,
you'll miss it all.
V1 through 6 will be
gone.
obviously absent, right? But I've come across many of those. I don't want to say tons of them, but you know, certainly enough that that it had to be brought up. Like, guys, you know, you sent this. It's kind of embarrassing. Somebody at the other end's like, they didn't even bother to put the precordial leads on, right? And it
half an EKG. Great.
And it's not helpful.
No.
There's not enough information there to determine.
No, it's not going to help it's not going to help the patient. It's
right,
not going to give the
basically
physician.
all you can on the receiving end is you may as well just send a rate and rhythm, right?
Yeah.
They have
Pretty
electrical
much.
activity.
Yeah, right.
Yeah.
Right.
Well, and I think to Caleb's point too, one of the things we have to remind all the agencies is we would always recommend that you maintain your equipment per the manufacturer's guidelines. So if we're talking specifically to Stryker LifePak 15, ensure that you're making sure your equipment is being tested and you are doing PMs and being maintained, because in that they're going to test your cables too and say, hey, these cables are bad, they need replaced, or that allows you to make sure you're getting the best picture. So we would also recommend that,
and that happens
you have a good
often.
Maintenance program.
They'll catch things that we didn't even know were there. Like,
Of course.
it's
their job.
You've got some issues with this cable. We've replaced it.
Yeah.
I mean, don't get me wrong. We have a nice plan with them, but still, they're going to tell you if they find issues because, I mean,
Yeah, because it's going to affect patient care.
yeah, it's
100%.
important.
As far as placement of the 4-lead or the limb leads, pet peeves.
Not getting them on the limbs.
No, yeah, boy, that's what
They're called limb leads.
almost like you're reading your mind.
Oh.
So
You mean you don't want shoulders and
Upper stomach.
up in the belly.
Put them right here. Why not?
So, and I guess that's kind of a leftover, at least my opinion on this, is that's kind of a leftover from walking into the ED and watching nursing do that. Well, if you have a patient that's going to be there for hours, right, and they're going to move around, they're going to be on their phone, they're going to be eating their bubble pack and, and their Jell-O and whatever, you put them on the extremities for that routine monitoring.
Yeah,
it's
but
gonna,
that's
it's going to induce a lot of artifact. That you're absolutely right.
After
that is
they've already run a
after
12
the
lead.
diagnostic component of that, and now we're just monitoring rate.
So the
and
patient's
rhythm,
laying
right?
in bed picking off the black label, still off their limbs.
Right. That's after all that. So don't take don't walk in and see a patient in the ER and see the stickers on the torso and then be like, that's the way I'm supposed to do it.
They do it.
That is, they do it. Why can't I do it? Well, because we're going to then follow on with these precordial leads, with these chest leads.
There's also a reason why these are longer. It's so that you can reach the limbs.
Also, yes.
But they say right arm,
About to say,
left
I was going
arm,
to talk about some
left leg,
some mnemonics,
right leg,
but
not stomach.
Whether you remember the color coding or not, this day and age, I haven't seen one that doesn't have the RA, for right arm, left leg.
White to the right, smoke above fire.
Yeah. However you learned it, there's several different out there.
where does the green one go then?
Oh, opposite.
Whatever's left.
Whatever's left. When I started, that's all we had.
Right. First they added this, and then they added these.
Oh yeah, no, that's all we had.
Correct. All right. But proper placement on the limbs for the purpose of doing a 12-lead EKG, of course, is paramount to get all of that. Now, I guess the other thing that needs to be said is, although we're getting 12 views, we're only putting
10 stickers
on, right? Because two of them are bipolar, right? They're looking at from two different ways. So that's all, that's for an EMT. I get that often from an EMT.
And
why do you call it a
augmented.
12 lead, right?
Mm-hmm.
I'm only putting 10 stickers on.
And we have an augmented view too that takes two and divides it into one, which is kind of interesting too.
Basically two, right?
It's a guess, a computer guess based on really good guessing.
So yeah, that's the important stuff for the limb leads. How about the precordial leads? How about some pet peeves there?
Not getting them where they're supposed to be.
Not counting. Not counting intercostal
placing 1,
spaces.
2, 3 instead of 1, 2, 4, 3,
Yeah,
5,
yeah.
6. That's probably one of my biggest pet peeves you watch is like, they're like, oh, I have to go in order because they're all numbered 1, 2, 3. And it's
Right.
like, no, typically I'll place 1, 2, I'll place 4, then you place 3 because with your fourth placement, it's going to be mid-clavicular. Then you're moving 3 off
You mean
a little bit.
nipple line?
Yes.
Correct.
Or, excuse me, nipple line.
Well, no, I mean
No.
mid-clavicular is correct.
Well, yeah.
What I'm kind of poking at you is everybody's nipple line can vary, right?
Sure.
So mid-clavicular needs to be your target, right?
Yes.
So
And remember how big the clavicle is. Mid-clavicular is not where some people think mid-clavicular is. I mean, my clavicle is from here to here. So middle of that is about here, not here. So that is a pet peeve, especially when people do needle decompressions. You got to get that right. You see a bunch of them right here.
Yep.
So,
yeah, so we're going to place V1 and V2 on either side of the sternum, right? And then to what your point, we're going to
how
put,
high up and down?
Yeah, I was getting there next.
Okay.
Then we're going to place 4. I then personally do 6, right?
Okay.
I do
All right.
do 6, and then I split the difference on 3 and 5, right? As my
I can't do it without stickers.
you can't do without sticker.
That might be something we could throw like a picture up to
Yeah.
on this. Try to when we edit it, try to put a picture up of where all the leads need to go in this episode for the EMT providers
Right.
to show the
Proper
different
placement.
intercostal spaces. So if you're not just an audio learner, you can be a visual learner as well.
Sure.
And I think we actually have a picture of that in the protocol. Correct me if I'm wrong
Yes.
there, of where the placement of all the leads need to go.
Sure.
But the big thing with that too, in the placement of either the limb leads or the precordial leads, you need to make sure you're not putting it on a rib or on a bone, right? That's
is
another thing. A lot of
the
people,
space.
you need to feel with one hand and then place. It is spaced for a reason,
Yeah, and often we see them right on the clavicles. It's like, goo.
which is not going to give you the best reading either. So,
Artifact, yeah.
yep.
Now those intercostal spaces, that's the important part, right? Is actually counting, and this is kind of my pet peeve is actually counting down. And the other thing that I don't know, I found works for me is I count down close to the sternum. I feel like I can always feel ribs close to the sternum. Like
Caleb's skinnier, it'd be easier.
Right, but he's also probably got more pec muscles than I do, so it may be harder to feel out here, but it's certainly easier to feel closer to the sternum. As I've, again, personal opinion, that's kind of where I start. And we're going to count down to the 4th intercostal space, right? So we're going to start here, 1, 2, 3, 4, and I'm going to put V1 and V2 on either side of the sternum like we just talked about. And then we're going to go down 1, over mid-clavicular, right? And that's going to be where we were just talking about. We're going to place
4.
V4, right?
Yes.
And then we're going to follow that same all the way around back here to mid-axillary,
Yeah.
right? And I think that's the point I was going to start making is how many times
They're just
have
1,
we
2,
have
3, 4.
five, 6, and
Yeah.
they're all over here, where 6 actually should be.
Yeah, well,
Mid-axillary.
Mid-axillary is
versus
actually
more,
on the side.
A lot of times you'll see it more anterior.
Yeah, absolutely.
Yeah, and that's a problem.
Mid-axillary in most people is going to be almost at bed.
Yeah.
Because we have the same issue that when we do with ultrasound is I'm trying to get to look posterior. If I'm looking at kidneys and stuff, I'm burying my hand into the
Under the
bed
mattress,
to get a better look because you have to be pretty far. People will sink into whatever they're padded against. So mid-clavicular is typically right at the bedding.
Yep. So we've got 5th intercostal space over here. We've got V6. We've got V4 mid-clavicular, like we were just talking about. And then again, what works for me? You were working left to right. I personally, like I said, I put 4, 6, and then I split the difference with 3 and 5. Those are kind of my pet peeves of not counting the intercostal spaces and just kind of how many people have we seen?
well, what about the
like,
extremely obese people?
Okay, and
Right, same landmarks.
It's exact same landmark.
Find the rib cages don't change.
Nothing changes.
So, yeah, and
Rib
people
cage
use
is the same size. Honestly, between all 4 of us here, we all have a similar rib cage.
Size rib cage.
So
Yep. So I don't like hearing that excuse, though. I will tell you that, like you said before, nipple lines do change quite a bit.
Yeah.
So don't
And
go.
depending upon how much money you make and how old you are.
I've had so many. I mean, I've had so many paramedics recite that back to me. Nipple line.
No.
Let's not use that for any landmark.
But it was used. I was taught that way.
100%. I was,
I thought I came out wrong when I was like midclavicular, like or the nipple line. I was like looking at you.
Yeah,
like,
no, I was being
now.
sarcastic.
Gotcha,
Yeah, because how many times? I mean, how many times you taught a trauma class?
Nipple line.
Where do you decompress? Nipple line. Come on, spare me.
Yeah.
But I
Find your
mean, that
landmarks.
was something that you were probably taught when you learned, and it's now we have to get that out of our minds.
Absolutely.
And 12 lead education has come so far, even since like we've all went to paramedic school. Like
That
we didn't.
Now, granted, I started at a volunteer department, but that was the monitor I used.
Yeah, I started on a 10 for a very short period of time. Went to an 11 very quickly, probably within the first month, and then finally went to a 12. But like our 12 lead class, even in paramedic school, I remember it was one of the ER physicians coming in. It was Dr. Coleman, actually, who taught our 12 lead class. Yeah, it was like, all right, this is, goes over the 12 lead and stuff. But like we did not have the paramedic education. It was a lot different then. It wasn't as in depth now, and now there's a magnitude of books.
I
and
honestly
using
wasn't
resources.
taught to interpret EKG. We were taught to transmit.
We were taught more afterwards, after the initial
yeah,
certification.
yeah.
Personally, yeah.
Yeah, no, 100%. In my initial paramedic education in '99, we had exactly 0 education on 12 lead EKGs. That was the exclusive domain of the physician at that time.
Mm-hmm.
I mean, here we are, let's just call it 25 years later. I've seen that progress from we don't do it. We don't even have the capability. Like I said, I started on a 5 up here. Not even baked into that machine, right?
Yeah.
10 also was incapable of that. There was some capability in 11. And then, of course, the 12 is really where it started to come into its own in
I remember
the pre-hospital
how cool
setting.
the 12s were when they came out. I was like, that was awesome.
Yeah, well, I mean,
We're gonna do things.
that brought a lot of capability to pre-hospital medicine, whether it's that, but that generation of monitors, right?
Yeah.
It was the tipping point, was where we really started to evolve in the pre-hospital diagnosis. But all right, we've talked a lot about electrical type interventions, but we really haven't talked about the defibrillation. We talked, AED, of course. Some of those same concepts that we talked about for skin prep, that also applies when we're doing, when we're putting the defib pads on for
Sure.
an AED, right? Same thing. Now, they are literally a better mousetrap, right? I mean, they are stickier and gooier for a reason, but you shouldn't overlook that same skin prep mentality of, maybe I need to wipe them off.
Wiping off is probably the biggest.
Simplest,
Everyone
easiest.
has,
Yep.
yeah.
Yep.
You should always have a towel in your cot.
Yeah.
Mm-hmm.
Well, so my introduction to medicine was as a lifeguard. So we were putting AEDs on patients.
That were wet, yeah.
That were wet. So
Yeah.
always sticks in my mind because now I'm a physician and we've got sticker leads that don't stick on people. Whether that's the ones we use in the hospital, you guys use pre-hospitally, but getting that skin as dry as possible,
Yeah.
because we all see those patients that come in, they're profoundly diaphoretic, and it's amazed at how much water can seep out from the skin underneath those pads.
It was amazing.
Yeah. And then other skin contact too is if you get like fuzzy wuzzy, very hairy chest. That's why it's always good to carry at least 2 sets of adult pads is what we do in our place,
Or some sort of prep
or
razor.
in our department, or a razor.
yeah.
And it actually a lot like BLS CPR goes over that. And it talks about if someone's really fuzzy, so if that EMT provider's there and you take off their shirt, maybe you don't have a razor, put the first set of pads on, push them down real firm, and then rip them right off, wax them. As long as you have another set of pads to put on, then you put the next set of pads on.
But Ray, the priority here is delivering the electricity.
Yeah, if not, that's where you're going to get this. That's where you're going to not have good contact with the skin, and you won't deliver the electricity to the patient. You have to have good skin contact. If they're loose and your patient is extremely hairy, you're actually going to cause the arc or burn.
Yeah.
They will burn. It's just not going to be effective to the patient.
Placement's important.
That
It
is
is.
the
You got to look for underwire bras. You got to look for chains. You got to look for
Jewelry.
So you got to be careful.
Yeah.
Med patches.
Yeah, med patches are another thing. A lot of times, too, they preach about like a pacemaker in the right chest. The majority of the time, a pacemaker is not placed in the right chest. It's going to be placed in the left chest. Pretty rare occurrence. Yeah, it's just not. I know the video preaches that a lot, but that's a pretty rare occurrence for those.
But
yeah, good skin contact.
The skin contact, it gets overlooked because it's like you're focused on delivering the energy, but they're missing the key point in that, which is to deliver the energy
through the
well.
Yes.
You have to have proper adhesion. You have to have great contact, and if that takes a couple of swipes with a
razor or waxing something,
or yeah, right. It's worth the time, and I guess that's worth saying, right?
And there's a reason they hang part of that out of the bag, and it's the rest of it's sealed. Don't pre-open those because they will dry out.
They will absolutely dry out.
Yeah, and you want those nice and sticky.
Yeah, and those, maybe if you're not at if you're at a slower department, you do want to look at the expiration date.
100%.
A lot of people think, oh, this has an expiration date, it's bogus. The glue actually starts to degrade, or the stickiness of it starts to degrade, which you're not going to have good skin capture then. You're not going to deliver the energy through the heart like you want to from pad A to B, for lack of a better word. So, yeah, you need to keep that in mind.
The patches in my command car expire on July of 2026. I check it every shift.
Yeah.
But proper adhesion, and then getting the most surface area of that electrode in contact with the skin is going to yield optimal results. So it's worth the time to do the extra thing. And I don't know if that's been said enough over the years, right? Because
probably not.
It's just like
just slap it on,
slap the pads on, right? And likewise with that pad slap, pet peeve of mine is you look at them and they didn't put it on and then run it down and press it in, right? There's like ripples, or there's, it's humped up, or you could push on it and it feels spongy because it's hovering above their skin, right?
What about other people's patches?
Running that down and proper adhesion.
Other people's patches.
Oh wow.
So how often do you run into a non-compatible patch with your monitor, or what do you do with them? Do you work around them? Do you rip them off? Do you leave them in place? Because it says once you put an AED on, never take it off.
I think that's for the lay provider.
It is. But I think
you're
the basic needs to know also that if somebody else is using we're going to take that off and put ours on.
I think they can help too with like the familiarity, if I could talk, of your facilities too. So like if you have nursing homes, you have dialysis centers, what type of monitor do they have? And then you can anticipate that. Like our dialysis center uses Zoll. Maybe be familiar with what your facilities use, your nursing homes, what type of AEDs do they have, your dialysis centers, your medical buildings, medical offices. I'm not saying you need to go to every one, but if you can anticipate that, or a lot of those places will call the fire department and be like, hey, we're looking to buy a new AED. Which one should I buy?
What should I buy, right?
What should I buy? That's your key item to try to say, hey, we have these type of monitors, so if you got these type of patches, we're compatible now. And a lot of people just don't think about that when they're buying a product.
They don't.
100%.
So I will tell you that recently in Ohio, a bill was passed that within the next year, I think, or year and a half, every township park, let's say with a recreational field, I think it is, has to have an AED. So we are going to see a lot of cheap, misbrained, different AEDs all over the place. I think it's just important to know your equipment, and if you're not familiar with what's already there, maybe put what you are familiar with and get rid of that. Because luckily our township was nice enough to get a hold of me and ask, hey, what do you guys use in your squads? What do you want to see at the park? And it's like, okay, awesome, this. But you're not going to have that. You're going to have a lot of, they're going to be the cheapest just to check the box to say that we did it. And that's a good thing. No, something's better than nothing, but they're probably not going to work with your unit.
I think, for, kind of going on with that, if there is a situation where you have intentionally chosen a product for compatibility, right? That nursing home reaches out, hey, what should we buy? And you're like, do this so it's compatible with us. If you show up, you need to double check their work, right? Because we just spent the last 10 minutes going on about proper pad placement, and
one's pretty much in the left groin area in that picture, and the right clavicle.
If we come in and just hook our stuff up, we're just perpetuating the fact that they did may have done poor pad placement, they have done poor skin prep, they've done all these things poorly to begin with. So you got to go back and double check somebody else's work if you're looking for that level of integration.
I know you're not on board completely, but even AHA says, as a team lead, you need to be able to take and say, you're not doing that right. It needs to be done better. And that's the same here. I mean, that's AHA preaching that. Like, we need to be, you're not doing that right. We need to do this better.
So
I think the big thing is you just got to deliver that message in a gentle way, in a kind way, right? Like, hey, we're going to move these.
And don't get me wrong, they don't phrase it like I did.
No, but I agree with you. And I think to your point, you need to be able to show up, if you're showing up as the EMT provider, to look and be like, okay, that's wrong. I have to correct it. So, okay, we're going to remove these pads, maybe just put ours on and correct it and talk afterwards.
Yep,
the other thing, too, with pad placement that I want to bring up is them not getting too close.
100%.
So I think, if you have that small, petite child, I was just going to go with, like, let's go adult. Let's just make it easy and say you have that very petite 95-year-old cancer patient that has lost a lot of muscle and mass. As you're looking at your patches for your placement, you do not want those pads getting too close together. We want them to be able to actually shoot the energy or allow the energy to go through a proper vector. So if your pads are getting too close together, one of the good things you can always do is, look at where you're going to put your pads. If you cannot put your whole hand in the middle, then just go A and P. Just go front and back. Is another thing.
I was going to say, make sure you have child pads or you have correctly attenuated pads, because I've just had to review adult pads on a pediatric patient. Like, we don't want that. We don't want to deliver 200 joules of energy to a kiddo, right?
On the first shock.
But kind of building off what you said, the purpose of placing those pads is to get the energy vector or the direction between the pads to go through the heart.
Yes.
And the closer you bring them together, it's just going to basically skim in an arc over top of the heart and not cause the depolarization that we're trying to accomplish, or the reset of the heart for the EMT that we're trying to accomplish. If they're too close together, if they're too if
they're stacked,
if they're all very anterior, we've not kind of wrapped it around the side of the patient. So, you want to talk a little bit about anterior posterior placement?
I think we should.
I was asking Ray if he wanted to build on what he was just talking about, but
no, I think it's good too. And like specifically to our protocol, we talk about, if somebody is in refractory VFib or pulseless VTAC, we talk about if we have our normal placement, if you want to call this our normal placement, and we have defibrillated the patient multiple times and it's not been effective, maybe we need to send the energy. Maybe we need to change our vector and send the energy through the heart in a different direction. So we need to go, anterior and posterior with our patches. Not saying to remove these, leave these in place, and then take a second set. So something we all need to be cognizant of for not only EMT providers but paramedic providers is if you have the patient, like, I'm going to have to tell a little bit of a longer story, so I'm sorry, but if you walk in and you're doing CPR on a patient, and then you pause and you put your whole Lucas on at once, I'm going to tell you a little trick here. Your code stat, you're going to have a pause greater than 10 seconds. So what we teach...
Which AHA is not even shortening.
Yes, they are shortening.
Yes.
Yeah, 25. Yep.
Which they're correct on doing.
100%.
We need to...
We need to
be off the chest as limited as possible.
100%.
So you should have to do, like we teach in our place, you're going to do 60 manual compressions, right? So I'm going to do 30 compressions, slide the backplate on.
Backboard under.
Like if John and I are working this code together and I'm doing CPR, he should be able to put those patches on around me, or say, I need you to pick up your hands really quick and then apply it. You continue, right? So I've only paused, CPR for, let's say, 4 seconds. I continue to do CPR. And you defibrillate that patient. If you have a patient that is in refractory VFib or pulseless VTAC, you need to think about that before you're going to slide that Lucas plate on the back and then put it on, because not a lot of providers are going to stop, be able to minimize time off the chest, do A and P placement, and then reapply the Lucas, because we all love Fireman Lucas and it does a great job in freeing one of us up, but we need to be cognizant of the AMP placement, but also decreasing our time off the chest.
Or any CPR device. I
mean, any CPR device.
Lucas is most prevalent in this area, but whatever we're talking about.
Yeah, there's Aldo Pulse, there's other ones.
I miss him. He retired, but Donnie Zimmerman used to teach, pit stop. maneuver CPR.
Well, that's what we're
It's
teaching
fantastic.
this year. Actually,
Yep.
last year in my skills classes for this year, is we're talking about the first 5 minutes of CPR that Dr. Compenza talks about, of not necessarily all that stack of what he's doing, but having that routine of we're going to start CPR, we're going to put this pad on here, we're going to do this pad.
And when
now,
we do this, then
3 minutes later, we're going to put them on firefighter Lucas. Well, but Lucas can do better CPR. No, Lucas is good about doing CPR when you're moving.
Yep.
Mm-hmm.
It's good about freeing up people.
Yes.
But I've resuscitated successfully people that can't even fit on a Lucas.
100%.
we didn't even have it up until recently,
exactly.
to be honest with you. So, I mean, people
both are
were
effective.
resuscitated.
I just think you need to think early on before you apply that back plate. If you think you're going to do anterior and posterior placement, then just go ahead and at least at a minimum, probably in the first placement, do the posterior, slide the back plate, continue your manual compressions, and just know you have to get your anterior
Undoing
pad.
it is tougher than
It is.
doing
So,
it proactively.
What's the worst case that happens? You put an extra set
You
of pads
burn a
on
set
them.
of extra pads.
You
Yep.
either use them, but if you need them, then they're there versus not
100%.
having them. So I think that's huge.
I think it's good to understand, too, as a basic provider, that let's say that you have a patient that the AED is calling no shock advised. You get a paramedic intercept now, and then they start shocking. And you're like, well, what the heck? I think it's good to understand that the AED in manual auto mode is only going to recognize ventricular fibrillation as a shockable rhythm. And a paramedic might see something else and change that. So
It'll also do VTAC.
Don't be alarmed.
Pulses VTAC. But yeah, there may be other things that the medic sees that
That is shockable,
that
so they may.
that the AED
And that's no shot to you, I guess, as a basic provider.
yeah. Got medications in the BLS realm for cardiac. We kind of touched on aspirin being
Most important.
the gold standard, right? And it doesn't matter from BLS provider, ALS provider. What's going to make the difference here is in a cardiac event is aspirin. All right.
Can we talk a little bit about how that works? Not to take up
is it
more
an
time.
anticoagulant?
So I think one of the biggest things and the easiest way for me to pitch it, and correct me if I'm wrong, maybe to that EMT provider, a lot of those meds are like overlooked, right? Because I could go to CVS right now or name the pharmacy, insert the name here, and purchase aspirin, and I could take 4 pills, which is 81 milligrams a piece. So I've taken 324 milligrams of aspirin. What does that do to the patient? So if you have a patient that's having, an MI, a heart attack, or a STEMI, and they have that clot in one of those coronary arteries, essentially we want to try to make the platelets slippery, would be my easiest way to explain it, to try to get some form of oxygenated blood by there. So if that clot is blocking 80% of that vessel, I want to capitalize on the other 20 and make that
slip by.
I want to try to make those platelets slippery to try to skate as much oxygenated blood by to get south of that clot, for lack of a better word, to help that patient. So I think a lot of times we overlook it, and a lot of people think too, well, could I give aspirin, right? So we arrive, hi sir, you're having chest pain today. What meds do you take? I take 81 milligrams of aspirin, daily. Did you take it today? Sure. If I gave that patient 324 milligrams of aspirin, am I going to hurt that patient? No. So just give it, right? There's really the only real contraindication is if they have an allergy to it. Would be one of the biggest things that we want that provider to focus on. So I just wanted to take a little bit of a deeper dive as to how does the aspirin actually work for the EMT provider. That might be a little bit, maybe they know that, maybe they don't. And I'm sure that'll kind of lead us into nitro and how does it work.
Yeah, and kind of going to what we were talking about in the scope for EMT for Ohio, EMT doesn't need to call for that, right? It's like
correct.
You have chest pain. Here's your 4 aspirin. We do want to talk about some specific situations in a minute where you might want to withhold that. There's some clues, some things that are triggers that make maybe we shouldn't give the aspirin. We'll come back to that. Now we get into that leads, of course, into the nitroglycerin, and nitroglycerin in the state of Ohio for the EMT gets into some very clever verbiage, right? And that is the patient-assisted verbiage. And in the state of Ohio, we have they've defined that at a state level is if the patient's already prescribed it, you can assist them with it, right? Whether it's their medication or your medication, if they already have a prescription for it, you're greenlit to go ahead and continue giving it, right? And this applies to every other medications, like aerosols we just recently changed, but there's a few other medications that kind of fall into that as well. But then there's this other caveat, or EMS supplied medication if there's online medical direction. So what that allows the EMT provider to do is give the aspirin, get the 12-lead EKG, transmit that, talk to you as a physician, and then, hey, can I go ahead and give some nitroglycerin, right? And then yay or nay based on blood pressure, based on the presentation,
EKG.
based on the EKG, right? Anything else you want to say about
Nitro? I would say don't forget about erectile dysfunction medication.
spot on?
So if they've taken that within the past 48 hours, that needs to be a concern because we could cause profound hypotension. That's sometimes overlooked.
Yeah, and I guess that brings up a nice point. Some of the erectile dysfunction medications last longer, some last shorter. We intentionally just said 48 hours to make sure everybody is safe.
Yes, in our protocol specific.
In our protocol specific, right? We broadened that for safety purposes. But if hey, this is a shorter versus a longer acting, it's never inappropriate to call and
just
ask med control
ask.
and be like, hey.
And nitro doesn't save lives; it just reduces pain.
100%. Yep.
Correct. I think, and that's the other thing too to the EMT provider listening is, well, how does that sublingual nitro work, right?
Yep.
So we give them that pill, and the easiest way to say it is all we are trying to do is make the vascular access, right? Their pipes, we're trying to dilate them. We're trying to make it larger. Yep. So my example that I always give to EMTs is if I have a gallon of milk in a gallon container, I'm now going to dump that gallon of milk into a 5-gallon bucket. Container. I still have a gallon of milk. I made the container larger. I've decreased cardio-oxygen demand, right? I've decreased pain to that patient. So if I could calm them down, they're not going to breathe as fast. They're not going to be hyperventilating. We can calm them down. Pain comes down with that. A lot of people think, well, I'm just going to give you this pill to lower your blood pressure. That's
a side effect of the medication.
It does.
Correct.
Also does that.
It's actually a side effect. So our focus is, yes, we're causing vasodilation to an extent, which the side effect is a lower blood pressure. But by making that vessel dilated a little bit more, we can increase oxygenated blood flow, decrease the amount of oxygenated blood demand
100%.
that is going back to the heart. So I think it's good to, try to get that out to some of the EMTs are more curious as to the depth of these meds and how they work.
Just be aware also that sexual enhancement drugs like Viagra on that, some women may also take some forms of that. So it may not hurt you to ask if something was taken before you give a nitro.
100%.
To a male or a female patient.
Correct. And a lot of those medications or similar medications get used for pulmonary hypertension.
Yeah, absolutely.
So
and that might be why they're taking
another treat. It doesn't necessarily need to be for a sexual reason. Anybody that maybe we should have kind of a hair stand up a little bit and maybe not give aspirin to at any level.
If you have concern for a aortic dissection, those are patients we do not want to give aspirin to.
Absolutely not, yeah.
And we're talking about aspirin being very important, and it is important. And the typical dose, the dose that we talk about, is not necessarily 324. It's, I'm going to do math now.
Math.
It's
Numbers.
162 to 324 is the benefit range, right?
Yep.
It's in that range that we're looking at. And it can be up to 24 hours post-event. Obviously, the sooner we get it, the better. But if we're delaying to make sure they don't have a dissection because we want those platelets in that to hold whatever's being held together right now, we don't want to break up that adhesion and make the dissection worse.
Correct.
I've had a personal experience where we had a STEMI we diagnosed on a patient, and it was myself and the interventional cardiologist staring at a CAT scan image, making sure, because the patient had ripping, tearing chest pain with syncope, that is this not a dissection before we then load them with Bronto or load them with heparin, give them aspirin, and then take them to the cath lab.
Yeah.
So those are the patients that it's worthwhile to take the time, because those are medications you can't sometimes take back and can cause a lot of harm to that patient.
How do I differentiate as any level of provider? Because
That
this
goes
really,
right back
this
to our
really,
beginning conversation.
this is
Talking to your patients,
yeah.
right? Unequal blood pressures. If your blood pressure on your right arm should be higher than your left arm if you're dissecting. If you're having tearing chest pain starting anterior and going towards your back, it's a classic sign of pain. If you have neurosymptoms, specifically in the left leg, if your left leg has numbness or tingling or decreased sensation or motor sensation, that can be a sign of aortic dissection as well.
Yeah.
Tearing, shearing.
Yep.
That. And then the other thing, too, to kind of add on to that is if you have that patient and you're that EMT or paramedic provider, you do the 12 lead and you call, that's why it's very important. And we kind of didn't touch on this a little bit is we should be obtaining the 12 lead prior to giving any medications, right? And so if you're an EMT and say this patient saying, I'm having this tearing, this shearing chest pain, I should put in my 12 lead EKG, I should transmit it, and I call, then the physician can also pick up on that as well. No different than the EMT provider should, and so should the paramedic provider is, okay, you transmit it, and the EKG is clean. That should definitely be a huge red flag to the physician and the provider to say, hey, maybe this is a dissection, not necessarily a STEMI.
Yeah. And we're looking for those. Typically, we're looking for those classic signs of that crushing, that dull, that dull chest
sudden
pain.
onset.
Yes.
The other thing I would also talk about when we're talking about STEMIs and that is basic, advanced doctor even. Women typically present differently, right? So we're talking more abdominal pain, nausea, and that was my subtle. But that was my patient we had. She was syncope with abdominal pain. Yeah. That was a patient that had a STEMI that we had to rule out a dissection for. Yeah. EMS missed it pre-hospitally. I got it in the emergency department, but things we don't want to miss. That we should have a high likelihood that belly pain in the appropriate. I'm not saying a 16-year-old is going to be having STEMI, but my case was a 40-year-old female abdominal pain, syncope. She was having a STEMI.
More oxygen's good, right?
No.
Oh.
Free radicals. Triggered.
Yeah, I should just put. I mean, I certainly remember my EMT training. In the mid '90s.
Crank it up.
15 liters. Fits all chest pain cases, right?
Yep. Morphine, oxygen, nitro, and aspirin. Right?
Yeah, absolutely. Mona greets all chest pain patients.
Yep.
That's crazy to see how that's adapted and
no
gone
kidding.
away.
So, if we have a pulse ox of 94 or greater, we just need to
LSD.
Really,
Like diesel.
only if the patient has dyspnea, if they have shortness of breath, we certainly can give some supplemental oxygen, a couple liters to basically to help them feel better. But we don't need to blast them with 15 liters by non-rebreather, right? As long as that pulse ox is in the, and if it's lower than that, then supplemental oxygen to get us a little bit, right.
And we're not aiming for 100.
We're not aiming for 100, just north of 94, north of that.
Yeah, that's a good point, because giving too much oxygen, which we've learned over time and from more data, is going to cause vasoconstriction, which is not good. If we have a clot in that vessel, that's actually going to impede progress. So that's a good point. A lot of people just overlook it like, it's oxygen. I can't hurt anybody with oxygen.
Can't hurt anybody with oxygen, right? Yeah.
Just
like you can't hurt anybody with Narcan, and you can't hurt anybody with, everything's a poison. It's just the dose that varies, right? Or can be a poison, I should say. All right. Guys, anything else that we need to hit on for the EMT provider? I think we got a big swath of stuff.
Man, do a good bedside assessment.
Yeah. Just history matters.
History matters. I think your communication skills, obtaining a 12-lead EKG early, and then early communication to the physician in the emergency department for that interpretation. But having that story to go with it, I think, is very important.
I would even say to the patient, too. Like, hey, sir or madam, I think you might be having a cardiac event. We're going to do a lot of things really quickly.
Yep.
And then just kind of go with the flow. If you have questions, ask along the way, but there's going to be a lot of things happening at once. And that's typically what I do when they come in and I've got a confirmed STEMI. Is like, hi, I'm Dr. Hill. You're having a heart attack. Cath lab's getting ready. A lot of things are going to happen right now. Answer our questions. They're going to be short and brief. And then if you have them, let us know. We'll answer as quickly as we can. And then 15 people are in the room, all tasked to do things, whether that's IV, cleaning up arms, checking legs, like getting them all the way into a gown, getting them ready for cath lab.
Intervention.
Yep. And if I can, I get a chest X-ray. If not, then they just go to cath lab.
My last pet peeve: control the time that you can. Decompress or compress your scene time. Do not camp on scene for 45 minutes.
Yeah,
get going.
Yeah, if you're
get going. That's a huge thing. Even if you're an
even
EMT
if you're
squad,
paramedic,
or even if you're a paramedic, do not camp on scene. Time. Get moving.
Also, know where you're going. I mean,
get moving.
If you know it's a cardiac case and you're very suspectful of it, don't take them to Conneaut. If you're in that area, take them to a cath lab, because that's where they need to be. and talk to the doctor.
Even if
obviously,
that extends transport time, that's the piece that
get headed to that direction at least. Yeah, if you know that center has the capabilities.
Send the tracing to CARDIOt if that's the case, and say this is what I've got. And the doctor there is going to say I can't treat it. Keep going. Are they stable? So and I don't know how often are we flying STEMIs that way anymore? Any? From that area.
From that. Incidents of that. Not a ton from the scene.
They're not saving too much time waiting. So
and periodically from the EDs, but I have no idea how many of those presented to EMS or how many presented to the hospital.
Just being sure to get them to where they need to be. I've always pushed that.
Well, go do what you would do for one of your family members, right? If you thought that was your family member having a heart attack, what would you do for them?
Yeah.
Take them to that location.
Mm-hmm.
Sure.
Guys, anything else?
Skin prep.
All right, very good. Well, we'll catch you next time.